All right. Our first speaker that I'm very pleased to welcome here today is someone that we got to know through the Saliva Directs annual conference over this last summer. Dr. Carolyn Bannister is joining us from the University of South Carolina, where she is an administrative director of the Diagnostic Genomics Laboratory and a clinical assistant professor. Dr. Bannister's talk is titled Enhancing Concussion Diagnostics, Leveraging Saliva-Based Detection Innovations. Dr. Bannister, over to you.
Great. Hello, everybody. So today I'm going to be talking about some pretty innovative new work that is being done in our lab and in different places in the world, as well as other places in the United States. And one of the cool things that we're able to do is to look at different saliva biomarkers to actually detect concussion. So this is very novel. It's very new. It's only been around for a few years. So I'm very excited to tell you about it today. So concussion is very common. I'm sure all of us know someone or multiple people that have had concussions during their time. It's very common here at the university where we see quite a few student athletes who get concussions, as well as other students who just, are goofing around and end up, getting concussed for one reason or another. But this is very common with, 1.6 to 3.8 million concussions per year. Interestingly, women seek treatment for concussions more often than males. This has been historically attributed to societal acceptance of showing weakness after some sort of trauma. However, more recent studies have shown a significant dysregulation of progesterone, and especially women who are concussed in their luteal phase, which is the second half of their menstrual cycle, tend to have a lot longer recovery time, and they also have more problems overcoming some of their cognitive functioning and decision-making, executive decision-making. So this is something that is pretty important to address that hasn't really been addressed very well in the literature so far, since this is so new and we're just learning so many new things about it. The symptoms can be very wide-ranging, from headache and dizziness, nausea, disorientation, vision loss, memory loss. Some of the ones that aren't also listed on here are sleep disturbances or depression. So some of these are psychological differences that happen after a blow to the head that are pretty difficult to quantify. So this is a very variable, lasting with just a day, and they can shake it off. It could be 2 weeks. And I've had several people come up to me and tell me that it's taken them months to recover. So with the concussion and looking in a university setting, we often think of football, but it's not only football that has the most concussions. We also see this in hockey, in rugby, particular without the head protection, also in soccer with no head protection, even basketball when things are hard hitting. And one that doesn't jump to mind immediately, but is very important, are also cheer. So the cheerleaders who are being tossed in the air can have pretty serious concussions. And I've had, some cheerleaders have come to me and have had real problems with this that they've shared with me. So currently, the way that they are assessed is through the SCAT-6. This is done usually by trainers who are assisting on the sidelines of many sports. And this is really done with a few different steps of, can you walk a straight line? How many fingers am I holding up? Can you repeat these words back to me? Can you repeat the words back to me after 1 minute? So a lot of these are quick assessments that are done. This is usually done in an acute stage. If you end up with something longer than the acute stage, you would have to go see a physician, and they may schedule an MRI or a CT scan. This isn't always really helpful for concussion, and it's not helpful for duration and case management, but it does show the severity of the initial impact. And then right now, what is being addressed for what to do is to go and rest. I've been reading some things in the literature that this is kind of changing, that they think that that's not necessarily the best. It depends on the type and severity of injury. that some people need to start moving more quickly and that actually will help speed recovery. But currently, there are no agnostic tests that can determine whether or not someone has a concussion. So why would it be that you would be able to detect concussion in saliva? It's because of these cranial nerves that actually innervate and go into and end into the salivary glands. Because these neurons are so long, the way that they communicate messages quickly is through extracellular vesicles with microRNAs already compacted in them. This is able to share the message very, very quickly, even though the nucleus may be very far away from where the dendrites are, to where that they can actually get the information very, very quickly. These cranial nerves end in salivary glands. So these microvesicles with this information ends up in the saliva. So the first study that came to my attention was the SCRUM study. And it was really impressive because of the number of participants in the study. It had over 1,000 professional rugby players in England. They had a whole bunch of 106 concussed players. And then they had no injury controls. And very importantly, they had musculoskeletal injury controls. This allowed to say this is not a detection of injury, that this is a detection of a CNS or a brain injury. And they were able to find a panel of 14 different microRNAs that were differentiating between the injuries of concussed versus non-concussed athletes. Other studies have come up involving mixed martial arts fighters. They've also had youth soccer. They're looking at women. This one was very exciting for me because this was the first paper that looks like it's actually talking about women in particular. So I'm also interested in doing some of this research, but I'm glad that others are joining this. We also have other studies that are very helpful because of what can we do as far as treatment. And they've looked at, prolonging these concussion symptoms and how those microRNA profiles change over time, as well as, just mild traumatic brain injury. So, we can pretty much determine pretty quick when it's a severe blow to the head. But when it's a mild injury, when is that actually resolved enough for the student to return to class or the athlete to return to play? This has also been refined over time, which was very important because, like any new field, there's a lot of discovery that's happening and taking place. One of the papers that I found really interesting was this review on what is known, and this is a table of different microRNAs with a bunch of different studies. The first two are from England, and the second one, the DePietro 2021, was that rugby study that I was talking about. Whereas we have others this was an earlier study in 2018. These other studies are all done by the university or Penn State University, and they are looking at kind of different things. And a few things I want to point out is that we still have a long way to go, that even though concussion is prevalent, we still have to monitor when someone gets concussed. We don't always have a baseline unless we can recruit a whole sporting team, which is what I'm going to be doing. But when they come in with concussion, what is their baseline anyway? So this first one by Fenerchak and Johnson looked at prolonged symptomology and what is the microRNAs that are present in those samples. As you can tell, there's no overlap. So this one is much more recent. It probably has a refined protocol, but the N is always pretty key here. Of interest are some of these in the middle, and this one in 2018 is particularly important because it showed the correlation between microRNAs in saliva and the CNS microRNAs from patients who have had concussion. and they were very, very similar and has a specific profile. Then when we look at this one, which was serum and saliva, they did not overlap very well. And the findings of this paper actually were that there were not very good overlap between the serum and saliva, but the overlap between CSF fluid and saliva were very, very strong. And I'm sure that my recruitment into my study is going to be much higher if I only ask for saliva than if I ask for CNS fluid. So a couple of these other studies, this one's very important because this was done on professional NFL players who are retired. So they've had a whole career of concussion. And you see a very strong panel of upregulation of traumatic injury. This one, which was done the next year, were done with people with mild concussions. So as we can tell, a lot of the same markers were showing up, not exactly, but a lot of them, but they're different. So this can also potentially tell us what to do with concussion over time and how we can, better proactively help athletes and people involved in car accidents and the whole wide range of different types of therapy that may be needed. This may actually even direct therapy and how we can better direct it by having a diagnostic. So in my study, what I'm looking at, I'm going to start with our football team and also our cheer squad. And I'm looking at both not only our varsity players, but also the intramural teams. They're usually not as well equipped. They usually do not have the pads and the protection that they need. So this is important to be able to include them as well. And it will also increase my N over a single season. So with these, we'll be able to do baseline before they start play. And then once they become concussed, we will have a baseline to compare with. And we'll also be able to look at this over a little bit of time to see how that profile may change, coordinate this with what the trainers are currently doing and their decisions that the player is ready compared to what I'm finding in their saliva. Another important one is just what does a whole season of play, practices, how does that affect, all of these small hits that happen over time? We'll be able to look at that. That question was particularly asked by the physicians who are taking care of these athletes because there is a lot of concern for the health of the student athlete. I'm also going to be looking at the Children's Hospital Concussion Clinic because there we have both pre and post-pubescent patients that come in, and both of those will be able to tell and look at their hormonal differences and how that is dysregulated and how that may be important. This eventually will be expanded to all our sporting teams here because we do know we would be able to do the consent on a non-concussed person, which is also a little bit of a trick to figure out how to do consent properly if someone's already concussed. It's not so difficult with the Children's Hospital because they are children and we can ask a custodial parent. We'll be able to also examine concussions and non-athletes. This may be very different for people who have ADHD, who often are at risk for getting more concussions. So they may not have the same as someone who is a very good athlete, for example. So all of this kind of comes back to what will we do with this information? And I really am excited that even though we would be starting with pretty in-depth sequencing and pretty strong analyses, where we want to take this is a point of care option, potentially even a take-home test. How wonderful would that be for a parent whose child fell off the sofa and they don't know if they should take them to the doctor? Or how about a point of care test that we could put on an EMS, rescue squad to where they would be able to test someone right at the scene of an accident. So this is kind of where we're going. We're still in the discovery phase to find what is the best protocol that we can use and also the best set of markers, which may be targeted to the age of the patient or to how that injury was acquired.
Thank you so much for our next speaker, Dr. Julia Halterman. She's the founder and CEO of Saliva IQ Diagnostics, Inc. And Dr. Halterman's talk is titled Saliva for the Accurate Rapid Detection of Strep Throat at the Point of Care.
Thank you, Brittany, for that introduction, and thank you for asking me to speak today. It's my pleasure to be here. Again, my name is Julia Halterman, and I have appreciated joining these webinars in the past and learning from others that are doing saliva diagnostics and other applications for saliva. And so it's my pleasure to be here today and share what we're doing at Saliva IQ. So with that, my presentation is about our strep throat diagnostic at the point of care. So our mission at Saliva IQ is this. It's to pioneer the development of highly accurate saliva-based diagnostic tests which patients prefer and clinicians can trust. And our first test that we've developed that I'll share with you today is a test for strep throat. And to give you a little bit of background on that, here we are. So pharyngitis or sore throat causes an estimated 15 million outpatient visits each year in the United States. So my guess is you or somebody in your family or somebody you know within the last year has had a sore throat. We go to the doctor's office to find out, is it bacterial or viral in origin? How can we get treatment? And how can we feel better? So lots of cases going to the doctor's office each year. Now, strep throat is the only form of pharyngitis that requires antibiotics. All other forms are viral, and so antibiotics are not appropriate. Strep throat is caused by group A Streptococcus bacteria, and in order to get over that strep throat infection, antibiotics are appropriate and are advised. Now, approximately 50% of patients with pharyngitis are prescribed antibiotics, but only 25% need antibiotics, and that number is the high end of that estimation. That 25%. So what we're seeing is there's an inappropriate prescription of antibiotics to patients that have pharyngitis that's viral in origin, and they really don't need those antibiotics to treat their viral infection. So this is the problem. Over 3.75 million patients are being inappropriately prescribed antibiotics for pharyngitis each year due to the inaccuracy of rapid strep tests. So when you have a sore throat and you go into the doctor's office to get a rapid strep test, a throat swab is performed on you. And there's a lot of literature out there that shows that this has been in use for many decades, but that the sensitivity of these rapid strep tests on average is about 85.6%. So it's a low sensitivity, which means there's lots of false negative results that are being generated. And I mentioned on the last slide that there were 15 million cases of pharyngitis that come into the clinic each year. Of those, about 8.5 million are children and about 6.5 million are adults. And you can see the blue bars and the green bars here in these graphs in that those that need antibiotics and those that receive antibiotics, there's this gap. Now, children need antibiotics more than adults because the incidence of strep is higher in the pediatric population. But this gap here between the blue and the green bars for children it's a smaller gap than what you see in adults. And what's going on here is the Centers for Disease Control advises clinicians that when they receive a negative rapid strep test, clinicians are advised to run a follow-up throat culture. So what that is, it's where a throat swab is performed and bacteria are grown in a petri dish, generally in an external lab, and that's an additional cost and additional time of about 1 to 2 days to get those definitive results on if strep bacteria is in that culture. And this is commonly done in pediatrics. We've spoken with many clinicians across various different specialties. And what we're seeing is that these backup throat cultures are run constantly. Anywhere between 60 to 70% of the time that a rapid strep test is run, a follow-up throat culture is run. So what that does is it allows for that definitive diagnosis to come into play to where children are being more properly prescribed antibiotics, but still there's an inappropriate prescription when there doesn't need to be antibiotics prescribed for viral infection. And on top of that, there are currently no strep throat diagnostics on the market in the US that they all use a throat swab. There are no other testing options for samples. And what we've heard from clinicians is that clinicians have told us so many stories of being bitten, head-butted, kicked, and vomited on. That's one that I've heard multiple times. And it's because these throat swabs cause the gag reflex to be generated. It's very difficult, especially in pediatrics, to get an accurate sample that physicians can trust that they're getting an accurate sample to run the test. So it's these problems combined that lead us to our solution. So our solution is a saliva-based molecular diagnostic test to accurately and rapidly detect strep throat infection at the point of care. So we ran a clinical study and we published our research in the peer-reviewed journal Diagnosis back in January of this year. You can see our paper there, and you can see our results. And how our study worked is we recruited 102 participants, and these were at James Madison University Health Center in Harrisonburg, Virginia. And all of these participants came into the clinic with signs and symptoms of pharyngitis. They signed a consent form. They gave us a sample of saliva by spitting into a tube. And we ran that through our Saliva Q-Strep A protocol. And then participants also had a throat swab performed, and a rapid strep test was run per the standard of care. And then we also had a throat swab performed, and that throat swab was sent off to run a throat culture for all of these participants. And that throat culture is the gold standard diagnostic test for strep throat. So again, it takes 1 to 2 days to get results back. So we compared our Saliva Q-Strep A saliva results with the throat culture results. And of 49 positive throat cultures, we saw a match with 49 Saliva Q-Strep A positive results. And with 53 negative throat cultures, we saw a match with 53 negative Saliva Q-Strep A results. So we were able to achieve that 100% sensitivity and specificity within our patient population. And we're using next generation rapid qPCR technology so that you can have these results very quickly at the point of care. So our advantage is that unlike current testing, which requires an invasive throat swab, Saliva Q-Strep A tests saliva with 100% accuracy. Follow-up throat cultures are no longer necessary, and antibiotics can be prescribed appropriately. So as I shared earlier, there are a lot of problems surrounding throat swabs that clinicians speak to, but also that parents and patients speak to as well. And so for many patients and parents, saliva is the preferred option. And we've generated a test that is fast, inexpensive, and highly accurate. So you might be asking, why now? And why hasn't this done before? Why is it being done now? There has been a lot of literature within the last 10 plus years that has shown that saliva is a great diagnostic tool. It is very efficient and effective at diagnosing infectious disease, but all of the tests that have been developed in a lab. So generally those tests are slow with lots of steps, lots of reagents. They end up being expensive. And they require extensive training and know-how in order to perform these tests. But you get that accuracy, and you can achieve that 100% sensitivity with lab-based tests. And so our aim and our goal at Saliva IQ was to develop a test that was simple, it was easy to perform, anybody could perform it, that it was inexpensive, and that it could be rapid and you could get answers quickly, but that also it would have that high accuracy that we see in the lab, but taking it to the point of care. So this is a current testing protocol for the rapid strep test. So again, if you go into the clinic, this is most likely the test that's going to be run on you to see if you have a strep throat infection. There are many different manufacturers of this test. Quidel, I'm showing you their procedure card for this one. They have 4 steps. It takes about 7 to 8 minutes on average until you can get results. But you drop reagent, and this is what the nurse or the clinical technician generally does in the physician's office. You drop reagent A and reagent B into the tube. You then have the throat swab that you put in, mix it around 5 times, and it sits there 1 minute. You pull that out, and then step 4 is you put in the test strip, and this is a lateral flow assay. You wait 5 minutes, and then you can read the results. And if the red band appears in any intensity, then that means the patient is positive for strep. So again, 4 steps, 7 to 8 minutes until results. But if you remember, on average, and again, this is across all different manufacturers of these types of tests, the sensitivity for this test is low. And there's still lots of false negative results that are generated by this diagnostic test. But 4 steps, 7 to 8 minutes. Here's the Saliva IQ testing protocol. We too have 4 steps. It's a little bit longer, and 22 to 26 minutes until results. But again, you're getting that 100% sensitivity in the clinic. So the patient provides a saliva sample. A portion of that saliva is transferred into the first tube in our kit. It's incubated at 120 degrees Celsius for a minute. then very briefly put into a mini centrifuge in order to pulse the sample down. And then that is transferred to another tube in order to drop it into the qPCR machine and obtain results. So to determine whether the patient has strep or not, the presence of this upward sloping line and a number here under the CQ value, if you have that upward sloping line and a number, the patient is positive for strep. And if you have a flat line, which is also our internal control that's built in, that flat line means that strep is not present in that sample and the patient is negative for strep, but also you would not have a number here present as well for a negative result. Now, this process is already very simple and straightforward, but we're also working to automate portions of this step in order to make it even more simple in the clinic. So this is my last slide that I'd like to leave you with, and it might look busy, but I'd like to walk you through it briefly. This is what happens here on the left side of the slide, what happens when a patient comes into the clinic with pharyngitis. Currently, a rapid strep test is performed. Again, I told you that takes about 7 to 8 minutes to get a positive or negative diagnosis. You can see that there are false positives that are generated, but really what's of concern, especially to the CDC, is that there's a higher percentage of false negatives that are generated. So again, the recommendation is whether you have a true negative or a false negative, you don't know. So many tests are tested, so many patients are tested again. That follow-up throat culture is run again at an additional cost and time in order to get that 100% positive, that you can trust that diagnosis. Versus SalivaIQ, this is the new option that we're offering, is that SalivaIQ at the point of care, within 22 to 26 minutes, you can have the accuracy of that gold standard, but in a fraction of the time. And again, this is using saliva that's simple to obtain and is less invasive and more comfortable for patients. So that's the end of my presentation. Thank you for this opportunity to share this with you.
Thank you. Appreciate that. Third and final presenter who's going to be sharing with us today is Natalia Maman, and she is the founder and CEO of RT MicroDX. Ms. Maman's talk is titled Transforming At-Home Diagnostics, RT MicroDX's Innovative Approach to Accessible Healthcare. And this will be continuing a little bit on the strep throat train and all of these interesting things that are coming through, but I'll turn this over to you. Go right ahead.
I want to thank you for inviting me to this, and so excited to be sharing what we're working on, what we're currently working on. So I present you here our team MicroDX. I am the founder and CEO, and we are so proud to be the one and only AAA diagnostic solution, where we stand on 3 very important pillars, which is affordable, accurate, and at home. And I'll walk you through this. But before we do, I just want to say how, the Lancet recently published that over half of the global population lacks access to basic diagnostic for common diseases. And we can all agree that without proper access to diagnostics, many people will either get sick due to overtreatment and undertreatment. And Julia can attest to that from her last talk. But particularly in the US, the problem, we have a big problem of access, which stems from the fact that it's highly expensive due to high copays and high deductibles, also due to the lack of physician, which causes low quality of care and also long wait times just to see a doctor, to get tested, or even to get results. All of that hindering proper diagnostics. So we come in with our AAA solution, diagnostic solution, which is affordable, accurate, and at home. And I'm just going to show you real quick. This is just a prototype that I have, but it's literally a lab in the palm of your hand that is easy to use, affordable, and available. The plan is to have it available over the counter, giving you PCR quality results because we're running a molecular test, all with access to diagnosis and eventual treatment, all for an average price of a copay. Now, based on the paradigm that I mentioned earlier, we can all agree that patients want at-home testing, that physicians demand it to be accurate, and everybody seeks it to be affordable. Now, we all know that the pandemic has normalized the need for rapid and real-time diagnosis from, making sure that there's early detection for improved quality of care and quality of life, alleviate the overload in the patient and physician load, enhance healthcare efficiency using telehealth technologies. In fact, telehealth platforms currently don't even have good tools to properly test and diagnose patients. So unfortunately, all of these platforms are falling on the wayside because they're still making patients go to labs to get tested. And finally, we're all looking for cost-effective, for more accessible testing and diagnosis. So what does the market look like currently? There's a lot of there's a lot of different solutions that I have tried to come into the market as for home diagnostic, but unfortunately they haven't worked. And the reason they haven't worked is because they require complex electronics with devices that are expensive, that require storage, and that really doesn't allow for a user to use one item without the other. So they have to work together. And, we can expect that with different versions, the one that you have, that patients would have had spent on and invested on probably become obsolete. So it kind of breaks down the affordability and the accessibility of it. Now, what has worked and what has always worked, oops, sorry, let me just go back here. What has worked and what has always worked is this single use, no setup, easy to use, easier to administer and interpret, being the pregnancy test. And that is what we're trying to emulate. We're trying to emulate a solution that is as easy as a pregnancy test, but for common diseases. And not limited to respiratory infections or bacterial or infectious diseases, but really as an easy thing for a number of different applications, which I'll explain. So our unique value proposition lies in our pH-sensitive polymer that enables us to run a test that is highly sensitive using a molecular process, which we have chosen to be LAMP, and show the results on a simple LFA strip, making our solution affordable. And let me just show you how it works. So we start with mixing our sample with our reagents and our primer mix, which is essentially our target. And we have it undergo a DNA amplification method, which we have chosen, like I said, to be LAMP. And what we notice here is in the presence of the when there is no pathogen, so when there's no presence of the pathogen, the pH actually remains the same, because what we're looking for is the pH change in that molecular reaction. However, when there is presence in the pathogens, we can see a very clear drop in that pH in the reaction. So we then bring in our polymer, which is a foundation of our innovation, which reacts to the pH change of that reaction. Now we see here that the polymers are in form of a bead, and we have encapsulated these molecules that essentially are released upon the dissolution of that polymer. And that happens when there's a pH drop. So what we've really created is a pH sensor, an affordable and inexpensive pH sensor in the form of a polymer that will release polymers, that will dissolve, release polymers, and release molecules. And it's those molecules that signal a simple LFA strip, which is our diagnostic readout and an expensive readout. Now, what is really powerful in this platform is that developing a test for new targets only require a change in the primer mix and some of the sample prep upstream of the system. But no matter what we use, whether it's saliva or other types of sample, we are focusing right now on saliva, but it's open to other samples as well. As long as it's a pH change in that molecular reaction, the rest of the system remains exactly the same. Now, we have developed this as a low-cost testing platform that actually plays within any of these very large markets that currently use PCR or molecular technologies as a gold standard. So as you can see, strep is in there, and that leads me into my next slide, where our first use case is the use of saliva for the detection of strep throat. Now, I'm going to be a little bit repetitive to what Julia said earlier, but the big issue with strep is the fact that you either are over-medicated, causing antimicrobial resistance, but you also have too many instances of not medicating for strep, which are the main causes for kidney and rheumatic heart disease. Now, let me just say that from our research, every rheumatic heart disease case comes from an untreated and undiagnosed strep, and there are just too many of people who've gotten it, who live with it, and who die from it every single year. Now, Julia, you actually may recognize some of your work here. So we know that saliva is an effective method for detecting strep using DNA amplification, as we see in these papers. But we've also developed our own formulation for saliva using LAMP, and which shows high specificity and sensitivity. And with the limit of detection, actually, that's very low. It's at 25 bacteria count. Now, the plan is that we want to make this affordable and accessible. So we've worked kind of backwards into that process and saying, what would the consumer be willing to pay? And our research has shown that they're willing to pay an average price of a copay, which varies between $25 and $35. That's after you have completed, you have reached your annual deductible. So we have developed this with the simplicity of our components. We have developed this to keep the cost low, so we can sell it, so we can have it available at retail for the consumer at an average price of a copay. Now, we have developed a prototype. We've put it in a small device that works at scale, in size, and in volume. And like I said, this is just a prototype. It's clunky, but we expect it's going to be small in the palm of your hand. And we can see that it works at positive and negative control. And what you see here, so the lower well here that you see is where the lamp happens. And then we bring it into contact with our beads. And what you see here is on the negative control, the beads are completely intact. They haven't moved. But if you look at the top positive result, you can see that the beads have sort of like started to dissolve and release. And it's what got released that shows that second line. Now, what we are working on also, which is part of our innovation, is a use of a disposable and sustainable paper laminate battery. So for those people who understand that with LAMP, you do have to heat to 65 degrees. We're actually working on making this as sustainable as possible. So avoiding batteries. And we're working right now with an innovation of a paper laminate battery that really just heats up upon hydration. And then as it becomes, as it dries up afterwards, it kind of just, it's just paper that is completely, that just dissolves. So we are working right now in including that to make this as sustainable as possible. Now, we have also realized that to close the access gap, it was very important for us to not only give you an inexpensive test, but also giving you access to diagnosis and treatment. Because it's, if you are positive, what do you do? But even if you're not, if you're negative, what can it be? And what should you do? And who can you talk to? And what the problem of access today is, we would have to get you to go to see a doctor to get tested again, and so on and so forth. So we have developed a telehealth integration system that closes that gap in the diagnostic process by offering immediate access to a physician virtually and allow the patients to be seen and treated without ever waiting or leaving their home. Now, we thought about bringing this directly to market, but that would be a very, tough thing to go direct to consumer. So our best bet to get this to market is to bring it directly to pharmaceutical companies that will use this platform for their own pipeline of diagnostic. And that could be for companion diagnostics. That could be for, we'll have strep done, but it could be for any kind of in the research and development of therapies or vaccine, and also to bring these diagnostic products to market to the consumer. Now, in terms of what's on the market, we know there's a lot of antigen tests in there, and as Julia explained, they are low in sensitivity, and we're trying to put those, we're trying to get those to not be used anymore because they cause a lot of issues. But then you have all of these different types of point of care platforms that offer high sensitivity. But unfortunately, even those that tried to use these platforms for home have shown to not be sustainable for home because of this two-model system. So then we come in here with this low-cost, single-use, disposable, readerless solution that would work for bacterial and viral pathogens, and with our integrated telehealth actually closes the gap in diagnostic access. Now we have, to date, we have completed our proof of science using LAMP and saliva. We have completed our proof of concept with the development of our technology, which is a polymer submitted for patents, and even launched our prototype. Now we're on queue to complete our product development for consumer, like our consumer final product solution by the end of next year. And then we'll be developing a whole bunch of different assays, starting first with saliva, and then opening up to different types of samples, and then go into clinical trials for validation, and then go to market into licensing. So this is our team, very strong executive team made of great scientists and a great advisory board. And the thing I want to spotlight is the fact that we have been accepted into this great program that's a collaboration with Roche Diagnostics that are helping us accelerate in the development of the R&D and go to market. They feel like this is sort of like the way to penetrate the direct to consumer market with this home test solution. So this is what we're doing. We're trying to close the gap. Bill Gates said it best: diagnostic testing is one of the most powerful tools to improve global health. He also agrees that people around the world still lack access to affordable and accurate diagnostic tests, and we are here to make that happen. Thank you so much.
Thank you. Appreciate you sharing about your work and your efforts and where things are headed. It's really great to see another example of a non-invasive sample type really trying to deliver an at-home solution or more accessible solution while still maintaining that high sensitivity. One of the questions that just came through is how is this envisioned for multiplex infectious disease, for example, respiratory or diagnostics like periodontal disease, that is using LAMP with respect to cost and capacity?
So we currently are working on this, one indication, one test, but we are working on it with the plan to make this multiplex. So, there's a very big difference, and many of you probably would understand this better than me because I'm not a scientist, but a multiplex is when you put a whole bunch of different primers into one pot, and then you just hope that they kind of like separate into the right readout. We will do more of a multi-panel where there'd be different pots for different indications, still in the same device, in the same single-use device. So that we envision that to happen, and we are developing it with that in mind. But we won't even start that until we complete this one test, this single test platform, and then go into multiplex. But it is being developed with that in mind.
Fantastic. I think it's the logical step for many of our teams that we're looking at this one item right now, but with the idea that it can grow and expand as we've heard out on this from our other co-presenters on this presentation today. One question that was actually on my radar is I thought it was, I appreciated that creating a sustainable disposable pocket lab is something that's on your radar. Is that motivated by anything in particular? Is it because of those future international approaches? Where did that concept come from?
Well, nobody likes to throw away batteries. Nobody likes to throw away, heavy plastic that doesn't decompose. So we have that in mind in developing this. I think it's on the mind of everybody. But people don't know is, pregnancy tests also have batteries. When you have that digital readout of pregnant, not pregnant, it has a battery, but nobody likes it. We use it because that's all we have. So making things sustainable to us is also very important. I don't know how, sustainable, like how much we can stretch that sustainability aspect, but at the very least, working on this sustainable battery with this vapor laminate, I think will take us closer to then, making all the other components more sustainable. So really keeping this in mind the whole time. Now, Lucera, had a great product. I don't know if you guys know about it, but they had a great technology, but it was single use, but it was a very heavy piece of machinery that was thrown away each time with 2 AA batteries. Now, granted, you could take away the 2 AA batteries, but you can't guarantee that would happen. So when you see all the things that people were not happy with along the way, along all of these solutions that didn't work out, and what were the issues with that, we're trying to address all those in our solution.
Yeah, thank you. Appreciate it. Really appreciate you sharing what you're up to and being able to be a part of our panel today. Thank you so much.
Thank you very much for having me. It's a true honor.
One question that did sneak in after the fact, actually, for Julia, before we close out, if we can just tag back over, is for what you shared, Julia. Do you envision that the patient would wait in the waiting room for the result, or would they leave and the physician would call in a prescription if it's appropriate?
Sure, that's a good question. So I've actually talked through workflow with multiple physicians and a couple administrators. There are different ways that this can happen. So you can have, again, you could have those results within 22 to 26 minutes. So oftentimes, especially in urgent care, the sample is taken. It depends on the clinic, but the sample can be taken before the physician actually sees the patient, depending on how they have things set up. And so that would allow time to collect a saliva sample. And then by the time the physician comes into the room, you could have that readout. You could potentially have patients wait there, but I've also heard of some other, again, as we've talked through ideas with physicians, the patient can leave and then they simply get the e-script sent, and they, a quick phone call saying, you're positive, go pick up those antibiotics. So there's different ways that this can work depending on the physician's office and how that could be carried out.
Absolutely. Absolutely. It's really interesting to think about the whole arc of all of these tests, because obviously you have to make sure that it's accessible for the patients, but how does it work in a doctor's office? How does it work out in the real world? And those kinds of configurations that are their own set of challenges. Thank you.
Sure.